Okay, now we're live. Cool. So
Let's
just
start watching the numbers.
Yep.
See if anybody wants to talk to us today.
So we'll kick off in a couple of minutes. We'll just let a few more participants flood in for this fascinating talk we've got planned today. How's the weather down in Wellington, Mel?
I'm not in Wellington today. I'm in Wanganui.
Oh, okay.
It was horrible this morning, but now the blue sky. So getting better.
Yes. I just want lighter mornings. That's what I'm looking forward to. Fed up with getting up and walking the dog in the dark.
How many more? We're starting to stabilize a bit. Okay. So yeah, we might just make a start.
Cool. Okay, so a warm welcome from IMAC to the session today. As this is a webinar, we can't see you, but you can see us. We appreciate you being here with us today, and where we will cover some clinical contents in regards to the Fisa vaccine for vaccinators. So kia ora koutou katoa, my name is Renee Stewart. I am the COVID education facilitator in the Midland region based in Tairāwhiti, Gisborne. Like to introduce you to my colleagues who will introduce themselves actually. So Olivia, you start.
Hi everyone, my name is Olivia Haslam. I'm the COVID immunisation advisor for Midlands based in Hamilton, and I'll be presenting today alongside my colleagues from IMAC.
So kia ora everyone, I'm Jane Morfitt. I'm the COVID clinical education manager, and I'm just going to jump on at the end and I'll be available to answer any questions.
Kia ora, my name's Melanie Miller and I'm the Central Region COVID Immunisation Advisor based in Wanganui, and yeah, I'm just here to answer your questions.
Typing away in the background.
Yeah. I will be typing away in the background.
Great. Now, please note the buttons at the bottom of the screen. The chat function has been disabled, so you don't put any questions in there. We won't be answering any of those questions if you do, but please put questions if you do have them in the Q&A area. We will endeavour to answer them at the end if the questions are related to the hot topics of today. So if there are any other questions not related to the topics that we are covering today, we will take note and record them, and we will endeavour to answer them another time, maybe in another webinar. Okay, so I'm going to kick off and start. So tēnā koutou no mai haere mai. Today we'll be discussing the clinical content refresher for vaccinators. So next slide, please, Olivia. Okay, so first off, the time frame between the first dose and second dose. So to be fully immunised with the Pfizer vaccine, people require 2 doses given at least 21 days apart. Vaccinators are advised not to give the second dose earlier than this, and while longer spacing is acceptable, the recommended spacing is for the second dose to be given as close as after 21 days as possible. Now, we want to emphasise that there's no maximum spacing. So better than that someone have the vaccine 6 months after to get the second dose, they're not getting it at all. But to get that 90 to 95% protection gets as close as to 3 weeks. So there is a really good reason sometimes to have an early dose. For example, prior to chemotherapy, also prior to travelling to a high-risk country. They need to seek medical advice via at least, the 800 number. If agreed that they can have this dose earlier, they will need to be given a prescription or a standing order, as the vaccine is only licensed by MedSafe to use 21 days or over. Okay, next slide, please. So this is another hot topic, is as you already know, yesterday in the Ministry of Health guidelines, this has come up as well. So extreme body sizes. So if you come across an individual with that's very extremely thin, we recommend you use the usual 25mm needle, but you may need to bunch the skin to ensure you enter the muscle. So avoid injecting too shallow, for example, subcutaneously. If you go into the subcutaneous fat and not the muscle, the person may not get suboptimal, less of a response to the vaccine. Okay, so next slide, please. And so on the other end, when you've got an individual with a large upper arm, so you need to estimate and make that clinical judgment, the depth of the skin surface to the deltoid, to decide whether or not that 25mm needle would be deep enough to reach the deltoid muscle or the thigh muscle. So the Pfizer vaccine is an intramuscular vaccine, so meaning the needles need to go deep into that muscle, either the deltoid or the vastus lateralis muscle in the thigh. So if the needle is not long enough to inject subcutaneously instead of the muscle, the chance of irritation and inflammation increases. So fat tissue also has poor blood supply, which can lead to poor absorption of the vaccine. Therefore, it is important to inject the vaccine into the deep muscle. So vaccinators should also have longer needles on hand, and they are trained to be discreet about using and upping the larger needle size. But if in doubt, we always advise people to use the longer needle. It will never do any harm to have slightly longer needle, and it doesn't hurt anymore. So which is the bit that most people have a misconception about. So each vaccinator requires easy access to vaccine drawn up with a longer length needle to avoid having to go and draw up one. So resulting in delays and stress for the client. So towards the end of the day, if the vaccine has not been needed in that larger syringe, draw the plunger back, pull the vaccine from the needle into the syringe, swap to a standard 25 gauge 25mm needle, expel any spare vaccine back to the 0.3 mils, and then give in the normal way. This will prevent any wastage vaccine. Thank you, Olivia. Okay, now the question, in New Zealand, are we currently vaccinating 12 to 15-year-olds? So MedSafe has not approved a COVID vaccine for use for any children under the age of 16 as yet. So a number of countries have already approved the age of 12 to 15. However, New Zealand, the current guidance remains 16 years and above. Okay, so vaccinators, you really do need to make sure that you're checking thoroughly people's date of births. I always think that there's also quite a handy tip to come onto, if you're coming onto your shift, to write down the year a 16-year-old would have been born in. So for example, 2005. So making sure that you are checking thoroughly. Okay, next slide. So the question around boosters. Okay, so will we require boosters? No one knows yet. So it's not yet known. Time will tell. So there's not enough time that's passed since the first vaccinations were given to be able to answer this question. Thank you. Actually, there's also more information on boosters and variants available on our website under webinars, and we do encourage you to watch this webinar. Okay. Okay, another hot topic is pregnancy and breastfeeding. So pregnant women are now encouraged to get a COVID-19 vaccine at any stage of their pregnancy. Although not initially studied in clinical trials because of the large number of pregnant people who have been vaccinated globally, there is no safety concerns with receiving the vaccine. So pregnant women can become very sick if they get COVID-19, therefore it is encouraged for them to get this vaccine. Some protection has also been evident that passes to the baby through the placenta and breast milk. Now, anyone with questions or concerns about receiving this vaccine in pregnancy is advised to discuss, you know, with the GP or midwife or yourselves. Yeah, so thank you. Next one. And breastfeeding continues. So there's also no safety concerns with having the COVID-19 vaccine while breastfeeding. So women do not have to stop breastfeeding to receive the vaccine. While lactating women were not included in the phase 3 study, as with all scheduled vaccines, there's no safety concerns about the Pfizer vaccine to lactating women. Okay, this is my last slide about fertility in Pfizer vaccines. So the mRNA does not enter the nucleus of any cell, which is where the DNA is situated. So no components of the vaccine reach the sex organs, and there's no evidence that Pfizer vaccine affects fertility. So there's also up-to-date resources found on the IMAC website, so please go visit that site. Now we'll pass you on to Olivia, who will carry on with the next slides. Thank you.
Thanks, Renee. So I'm going to flick back to how you become a COVID vaccinator. So as you can see here, there's currently 3 pathways to become a vaccinator in New Zealand. So we've got our traditional pathway, which is the authorised vaccinator. This is the traditional route of most of our vaccinators. So these are health professionals, normally a nurse or a pharmacist with a current APC and a CPR. The CPR requirements used to be level 4. They're now level 3 plus IM adrenaline, as it's been decided we don't need that intubation skill, and it makes it a bit more accessible. So for the likes of St. John's and 111 Care, they actually call that CPR course now Vaccinator CPR. The CPR requirements are the same for both a provisional and authorised vaccinator. Okay, the main thing being able to be able to safely administer first aid to someone having an anaphylactic reaction, which is the most concerning but rare side effect of vaccines. So the authorised vaccinator, it is the most comprehensive course. It's the most comprehensive course that we do. So they have the biggest scope and also the most training. So they do a 2-day face-to-face course. They have to pass assessments, multi-choice question assessments and clinical assessments as well, which are rather in-depth. After this, they submit all the documentation to the local medical officer of health to get approval. Once that's come through, they can administer all vaccines on the national schedule. To maintain, they have to have 2 yearly updates with peer reviews and that ongoing authorisation from the medical officer. A pharmacist vaccinator does fall in this category. They do the same training, except they have a more limited schedule of vaccines that they may administer, and we don't do children and babies either. We do 13 and over. Late last year, the provisional vaccinator pathway was made available. You've got a broader category of health professionals. They do have to be registered. That's still a requirement, and it lies in legislation that it has to be a registered healthcare professional. So I'll quickly rattle through them, but they include registered and enrolled nurses and pharmacists, registered and enrolled nurses, pharmacists, healthcare students, so final year nurses, midwives, pharmacists, paramedics, 4th year onwards, medical students, midwives, paramedics, physios, occupational therapists, dietitians, speech language therapists, optometrists, those registered with the Dental Council. It's an extensive list because we need a nice big vaccinator workforce. So if in doubt, details are on our website. So these vaccinators do 5 hours of online learning and a multi-choice assessment. There's a video in there on administration. Then they do a peer assessment, which must be done by an authorised and experienced vaccinator or pharmacist vaccinator, who is willing to assess you in your workplace. Otherwise, IMAC can facilitate with that. Experienced vaccinators mean that they've got to have 2 years or more of experience as a vaccinator. They will observe vaccinations of at least 2 patients and fill in a peer review form. This will be required to be completed under a prescription or standing order. That documentation all goes through now to the Ministry of Health. Previously, that was to IMAC. The Ministry now hold that, so they're keeping track of all of these pathways. So you apply it to the Ministry of Health. There is currently a little bit of a backlog. So if you've sent it off and still waiting, it shouldn't be too far away, so hang in there. The main thing is you can't vaccinate until you get your authorisation letter through. That authorisation lasts until the 30th of June 2022. Once you've got your authorisation letter, you will be able to administer flu and MMR vaccines to 3 years and older, or in the case of a pharmacist, 13 years and older for flu and MMR. Once the authorised or provisional vaccinator is qualified, then they have to go on and complete the COVID-19 vaccinator education course before they can administer the Pfizer vaccine. So this is the qualification, and then they just go on and do this education course. There's no assessment, it's about 3 hours, you do it, and then you print out your certificate and you're good to go. Then we have this brand new pathway. There was a webinar which ran yesterday, a Q&A webinar, which was run with Ministry of Health and IMAC. It is recorded and there will be 2 more sessions, so I'd strongly recommend to watch that if you're interested. I'll quickly run over it. Basically, an employer applies for this course. Individual can't apply for this course. They do their online training, pass an MCQ. There was a face-to-face practical session. And then they have on-site supervision and a competency assessment by a clinical supervisor, where they observe vaccinations. They have to do a certain amount of observation of vaccinations under supervision and with a standing order. And they can only administer the vaccine under direct supervision of a clinical supervisor. So that's an experienced vaccinator. The key thing is they can't obtain informed consent. That's still got to be one of these 2 categories that are getting informed consent as well. Right, needles and syringes. This is a topic close to my heart. So this BD syringe, your 1 ml syringe, and your LDS needle, this was the original combination. It was working brilliantly. It was a bit tight to put on, but we knew we had a really secure attachment, and we were getting consistently 7 doses, occasionally 6, but on the whole, once you got into a good rhythm, you could get 7 doses per vial, which is 1 more than we expected, and so that was an added bonus. And we were able to get, the Pfizer vaccine was approved for 5 or 6 doses per vial, but using the LDS needles, we were able to reduce that dead space volume, and that's how we achieved that 7th dose. Unfortunately, in these international pandemic times, there is a worldwide shortage of needles and syringes. So unfortunately, our stocks of BD syringes are running low, if not out. So if you've got any, please use this combination. This is the preferred combination. Use it until you've exhausted this option. This was the replacement combination, the Vaccinators syringe and the LDS needle. There have been issues highlighted with this combination, causing air bubbles, leaks, and taking too long to draw up. These issues are when a Vaccinator syringe is joined to a Vaccinator LDS needle, resulting in a loose connection. This issue has been found to be widespread and is affecting many sites. Ministry of Health and IMAC do not recommend this combination as it's not fit for purpose. There have been no reports of this problem occurring when the non-LDS needles are used to draw up the diluent. So hence the advice now is to use the Vaccinator syringe with a non-loaded space needle, which is the same needle you'll use it for drawing up. This means we will usually only get 5 doses per vial. So we are swapping accuracy. We're swapping doses per vial for accuracy. So we need to get that more accurate dose, but at a cost of 5 doses per vial. It is unfortunate, but it means the safest option for the patient to get the most accurate dose. And it is only temporary, because breaking news is that we have some very clever people at the Ministry of Health have managed to source, in a world where there's hardly any syringes going, these Unifix 1 ml syringes by Terumo. They will hopefully be in the country very soon. Fingers crossed they'll be sent out to sites shortly. So if you see the Unifix syringe come through with your orders, please jump straight in with them. You can use them with the LDS needle. So don't throw away these LDS needles, they're still of use. So this is what we're aiming for, the Unifix syringe, 1 ml syringe with an LDS needle, and we should get back up to that 6, usually 7 doses. This is going to be the combination going forward. There was more information in that Vaccinator update released yesterday by the ministry, but yeah, do watch for that in your deliveries there. Just a reminder, I know Renee discussed it, but you must have larger needles readily available at all booths. You might have 2 or 3 black or green needles sitting in your little tray with the orange 25 gauge needles. You cannot just expect the vaccinator in the booth to just swap over the syringes, because that doesn't work. We won't have a primed needle in that case, and it's going to result in a dose lower to the patient. So in the end of this, if you've got leftover syringes with the larger needles on it and it's coming up to that 6 hours, take it back to the drawing up desk. There is a technique that Renee discussed to draw up, swap the needles out, and then reprime the needle. Communication is key here, but it is a practical solution, and it is important for all patients to receive a therapeutic dose. That is their right, and as a vaccinator, it's your job to make that clinical judgment that they have the right equipment used to achieve that dose. So please, all sites should have those larger needles readily available for the vaccinators in the booth. So preparing the Pfizer COVID-19 vaccine. There's a few documents going around, but this is the one that you're probably all well familiar with. This has been updated today, so please make sure you've got the most current copy. Check out our website, covid.immune.org.nz, and go to our written resources. It's important to check there frequently to make sure that you're working off the most relevant up-to-date documents. Now, these are observations that IMAC staff have observed when they've been visiting different sites. So what I'm about to discuss is actually happening out there, and the whole point of this webinar is to ensure consistent and safe practice across the board. So prior to dilution, please invert properly. It looks goofy, but do this. Don't just have a chin wag and do this. Do invert properly. I have seen some funny inversions out there. Please do check if the vial is cloudy. You need to know what is normal. We've had some vials be identified as cloudy, or there's been particulates in there, and that's only been discovered because the vaccinator's been doing their job correctly. So I know it can be a monotonous job drawing up, but each step is so important. These ampules, the 10 ml saline ampules. So open the ampule just before use. Do not prepare the saline in advance. You cannot draw up the saline the night before and have it sitting there in the syringe. Saline, the diluent, is for single use only and for immediate use. So the vaccinator must draw up the saline just prior to putting it into the vial. Now, if you had your saline, it is for immediate use, and I know it can seem a bit wasteful drawing up 1.8 ml of saline out of a 10 ml vial and throwing it away. If your person next to you was vaccinating and they were at that exact same step, you could pass to them because that is still immediate use. They're putting in a sterile needle, but you can't just sit there and hold on for that for 2 minutes. Okay, there's no preservative in it. We don't want bacteria getting in there. If you put it on the table to use in 5 minutes time when you're diluting another vial, no. Okay, single use only, immediate use only. If you've put it on the table, just throw it away. Don't keep the saline. You are provided with enough saline as per vial, so there really should be no reason to be holding or keeping saline not for immediate use. So you put the needle in and draw up your dose. You cannot attach the syringe to the saline ampule. Okay, if you've got to put the needle into the saline and draw up your dose. Otherwise, you're not having a prime needle and you're going to get a lower dose than you need. So when you put in your saline, you put your saline into your vial, and then you equalize by taking out the 1.8 ml of air. You may notice that there is some saline left in the syringe once you've completed the dilution. That is normal and to be expected because that's the saline that was sitting in the needle. So don't, I know some sites are then going back and trying to push in that extra saline. Please don't do that. That's just over diluting the vial. We talk about a clock face when putting your 6 doses in. So I use these little notches as my little guide when I'm drawing up my doses, to make sure you're not going through the same hole each time. I have seen some good practice insights because we are recapping, because these are the same needles that we draw up with as we administer. So a few sites, they use the foam inside the boxes to hold the needle cap so that they can safely avoid a needle stick injury. The packaging from the needles and syringes must be removed in such a way as that minimises touch. So registered healthcare professionals know how to remove these safely with a no-touch method, okay? These are nice and sterile. We cannot prepare these in bulk in advance. They have to stay in their sterile packaging until just prior to use. Otherwise, it defeats the purpose of them being sterile. So, yeah, they're taken out of the packaging, the needles and syringes, just prior to the drawing up, not the night before, not 2 weeks before, just prior to drawing up. Keep your drawn up syringes in a tray, which may be a kidney dish or a lunch box that can be wiped down, alcohol wiped between each use. You could have a couple of vials worth of syringes in one tray. So you could have 12 or 18 syringes all sitting together, but they need to have the same expiry time. So you're not going to be having a stack of 50 syringes there. So keep it reasonable, that they're all kept together so we can make sure that we're using the vaccine that's expiring the soonest. Diluted vaccine is stable in normal room light and is stable enough to be walked around the vaccination centre. We did initially think it was quite a stable, precious little thing. It's pretty tolerant. You can give it a bit of a flick if it does have any air bubbles to remove. So preparing the vaccine, you do need to have second checks completed by another vaccinator, and it needs to be documented. Often the vaccinator administering the vaccine is not the one who drew up that batch. So we need to make sure that there is a robust checking system in place for our colleagues so that they are confident for the vaccine they are administering has been prepared correctly. Only vaccinators may do the second checks as it comes under the vaccine is a prescription medicine unless the vaccinator who is trained is administering it. So it comes under legislation why only vaccinators can prepare it. You should be drawing up all doses from the vial at the same time, ideally, so that if you find less or more doses than expected, you can determine if there is a dilution error and whether you need to keep or discard this batch and make your reports. That leads on to my reconciliation point. Documentation is a big must and it should be done at all sites. This is an example of the dilution record that we've got available through IMAC. So reconciliation, you need to compare how many doses have come out of the fridge times how many doses you got from each vial, and compare that with your CIR reports with how many patients have been administered to. You need to have that, keep that record of who's completed that second check. We need more than initials. We need perhaps, first and last name, or it is an important audit trail. There has been an incident where there's been a problem found during reconciliation, and it would have been easier to determine the error if the reconciliation at bigger sites was occurring hourly, or at a smaller site, do it morning and evening. So if a mismatch happens where maybe too many vials have come out and not enough people have been injected, it's easier to find out where the problem has occurred. If you're using this paper system or if you're using a whiteboard, you must keep a record. There's no point keeping it on whiteboard and just wiping it off each night, because we need to keep track of that for an audit purpose. The dose is 0.3 mils. We have been asked this prior to this webinar. Yes, it is 0.3 mils. Once you've drawn up the 0.3 mils, you can't put the needle back in the vial. So ideally, your second check should happen while the needle and syringe is in that vial. You need to bring it up to the eye level when you're drawing up, and when the second vaccinator is checking, ensure that the rubber bung is at the top, is at the right spot. It is, could be a Specsavers moment. It is very small writing. You don't want the vaccinator administering being the second check, because to really give it a really thorough check and make sure that that's accurate, the poor patient sitting in front of them and seeing them wave around this needle. So it really should be those 2 second checks happening, the 2 checks happening at the drawing up table. It is worth noting, keep the needle on the arm. You've probably found this by now, for a couple of seconds afterwards, just to make sure no vaccine tracks when you take the needle out. When you're dealing with such a small volume, you don't want to lose a bit of that dose on the skin. Put your needle straight in the sharps bin. There have been reports where that they've administered an empty syringe, so we want to make sure that there is only clean needles on your bench with vaccine in it, just to minimize errors. When you're doing mass vaccination, you've got to have really clear processes, clear benches, old vials straight in the bin, old needles straight into the sharps bin. If you've ever got a query about, or do I need to redose them, you would be calling 0800 Immune or asking your clinical advisor. So expiry dates. As syringes must go out, they must have a label given to the vaccinator that includes the vaccine and diluent batch numbers and expiry. This expiry is from the vaccine box, not from the vial. So that vial expiry is 6 months from manufacture. That's relevant while it's in the freezer. Once it's taken out of that ultra cold freezer, that expiry is no longer relevant, okay? It's now got a 31-day expiry, which is what is printed on the white box by HCL. They also need what time the dose expires. So that's 6 hours after the diluent has been added, and you need the initials of who drew up and who double checked, so that the vaccinator administering is really confident that that's an accurate dose of that correct vaccine. The batch, I am seeing this, there's a lot of variation in sites, and there will be a bit of a crackdown as the CIR is now really starting to ramp up how they monitor batch numbers, but it needs to be correct. It's the batch for the vaccine will have a batch and a sub batch. So I think it's 3 letters and then 4 numbers and then a hyphen and then 3 numbers. So it is a bit long-winded. And that you can all get from the white box, okay? Don't worry about the batch number on the vial. What the batch and sub-batch are printed on the white box. That's what should be put out to the vaccinators, and that is what should be entered into the CIR. The recording into the CIR must be accurate, as it's now being double-checked. So screening and informed consent. So this has been updated recently. This one I've got is from the 28th of June. There's another one being released today. Okay, so this screening and guidance form is double-sided. On one side is all your screening questions. This should be at every vaccinator's table. So screening and informed consent is always done by a registered healthcare professional who have done their COVID training. Your consent can be written or verbal, but both techniques should be using this form to ensure you've covered all the required aspects to make sure that you're getting proper informed consent and that they are appropriate for the vaccine. Everyone has their own script that they like to use. I like to follow up with, you consent to me giving you this COVID vaccine today. Are you happy to proceed? Just being crystal clear about consent. So please do make sure that you've got the right consent form. As I said, it has been updated again as of today, and you can get that on our website, covid.immune.org.nz, and go to written resources. So these are the points that we're covering in that screening and guidance form. So identification, obviously, we're just checking the correct patient as in on the CIR, and that they're over 16. We're going to postpone the vaccine if they have a fever or they're systemically unwell. Allergic reaction, we do want to know about the history of allergies, particularly to vaccines or medications. The only contraindication is history of anaphylaxis to a previous dose of an mRNA COVID vaccine. So if they've had an anaphylactic reaction to their first dose, they're not going to be getting their second. If they've had an anaphylactic type reaction to medications, it comes down to a risk-benefit analysis, and that's a discussion perhaps with your clinical lead and the patient. Call 0800 Immune if you need help. More often than not, they can have it. They'll just be monitored closely for 30 minutes in observation. We want to know if it's their first or their second dose. We need to ensure there's a minimum of 21 days between the 2 doses, and the day of the first dose is what we'd consider day 0. Vaccination at less than 21 days is off-label use and requires a script and is against clinical practice and Ministry of Health policy, and it should also be loaded as an error into the CIR. The booking system tries their very best to get a 3-week gap between the 2 doses, but as a vaccinator, it is actually your duty to check that they are indicated. And you could, again, have the date that minimum 3 days falls in, so you can just quickly check that the date of the first one and the second one is correctly spaced. So we're asking about bleeding conditions or anticoagulants. All we want to know is how much pressure to apply afterwards. It's not an indication to not get the vaccine. We do not need to ask about vaccines that have happened in the last 2 weeks. It is safe to vaccinate people who have had vaccines in the last fortnight. It is still recommended at the planning phase or at the booking system that vaccines, if they've had their flu vaccine, so non-live vaccines and COVID, should ideally have a 2-week stand down or 4 weeks with live vaccines, as this allows for easier monitoring of potential side effects. But if they are at the vaccination centre, please give the vaccine regardless of when they've had their last flu jab. And then, of course, we're going to cover, do you have any questions? That's all you have to ask, okay? You will have tricky questions, you will have tricky patients. A really key message that we want to get out there is don't delay. If they are at the vaccination site, it's very, very rare that they should be turned away. See you later. So if in doubt, consult with your clinical lead or contact 0800 Immune for specific advice. But immunosuppression due to disease or treatment, there's actually no safety concerns. We would vaccinate them. We're not going to delay. We will try to accommodate them if their specialist has advised them about specific timing, but we don't need to ask about medications that they're on other than anticoagulants, as there's no medication that is cautioned to receiving the Pfizer vaccine. The COVID vaccinator doesn't recommend when to get the vaccine in relation to medication. There can be optimal timing sometimes, but if they're here now in front of you, just vaccinate them. If they want to arrange timing, they will arrange that at the booking phase. The immunosuppressed are one of the most vulnerable groups to COVID disease. We want them vaccinated as soon as possible. There might only be a minor improvement in antibody response if we alter the vaccination date, but with with cases moving so quickly in Australia and Fiji, so close to home, remember it takes 3 weeks between your 2 doses and then an extra 2 weeks after the second dose to get full immunity. The main message is don't delay. Do not pull patients out of a queue or get them to ring the specialist if they're in front of you on immunosuppressants. If they're there, please give the vaccine. The deltoid is the preferred site. I have been asked if we can put it into the gluteus maximus. No, it's the deltoid, please. Unless there's bilateral lymph clearance, then we can give it into the thigh. Same with a double mastectomy, and you just consider your needle size. Other brands of vaccines, there is a COVID chapter in the immunisation handbook, and this is covered there. So say they got AstraZeneca back in Australia. If they're going back to Australia in a week, I'd be, go home and get your second dose there, because we know how 2 doses of the same vaccine work. We don't have data on how mixing vaccines work. It is covered in the COVID chapter about how we anticipate to combine, say, 1 dose of AstraZeneca and 1 dose of Pfizer. And again, if in doubt, you would call 0800 Immune. If they come to you with like a funky medical condition or a weird sounding medicine, remember your red, amber, green, sort of red, amber, green, your traffic light system. Red, the only people not getting the vaccine today is that allergic reaction, anaphylaxis to the first dose. Caution is just previous anaphylaxis, and then proceed is everything else, okay? It's actually quite an easy vaccine to categorize like that. Observation, we have been asked prior to this webinar that no, if a patient is on mental health drugs, they do not need to be observed for 2 hours after the vaccination. Most patients will have a 20-minute wait. 30 minutes obviously would be recommended if they have an anaphylactic type history or if they've got concerns after their first dose. Check the patient is feeling fine before they leave. It is optional to check the injection site before they leave. It is a good idea, but not strictly required. If they try to leave early, you would just encourage them about why they're staying, but you don't have to tackle them to the ground. They are, they can leave early. You would just put a note in their CIR that they were advised otherwise, but they left anyway. It is why it's important for the vaccinator to mention there is a 20-minute wait prior to administration. And it's obviously, that's the key point of observation, to watch for anaphylaxis. Right, so I'm going to stop sharing and go over to Jane.
Thank you. That was brilliant. Just a couple of things to add in before I'm going to just do 2 or 3 slides, but I wanted to just clarify, MedSafe have actually approved the vaccine for use from 12 till 16, but what hasn't happened is the ministry have not agreed that the programme is going to roll out, nor have they agreed how that's going to roll out. So for the moment, absolutely correct, we are not vaccinating anybody under the age of 16, and it is important that we're checking that. So just to clarify that. We'll answer some more questions at the end around that have come up in around different resources and such like that are available. But I just wanted to also mention, while I think of it, that there's 2 new training online courses available on our website. One is for supporting decision making for people with disabilities. It's a very quick course, it's free, and I highly recommend that anybody that's involved in gaining consent has a quick look through that one. You will find there's some really quite interesting information in there, which we will be including the key messages in our training from now on, but obviously you guys have already been trained. And then we've also now put on a free access to vaccination training for support workers, so people can access that one and support you too. So I'm just going to share my screen. Bear with me one sec. I've lost that one. Doing 3 other things at once. Right, that's the one I want, that one. And okay, so I've been asked by CALM just to touch on a couple of issues around diagnosing anaphylaxis. Unfortunately, it seems that some people are being just a smidgen too enthusiastic with their diagnosing of anaphylaxis. And although it's safe to give adrenaline for the vast majority of people, and we don't want you to be too cautious, we equally do want you to make sure you are assessing carefully and that you do actually have genuine indication for the need of adrenaline. So to this end, CALM have produced a new document that you can see on the right-hand side here, this sort of colour-coded document. This is going to be sent out to all vaccination sites, and we will also host it on our website under our resources. This is a form that will need to be completed at the end of any time that anaphylaxis box is ticked on the CIR. Now, we're not suggesting you take that form and go through it during the emergency situation, because obviously you're thinking and you're assessing at the time, and you're all trained to manage anaphylaxis, so I don't want to be seen to be sitting here teaching you to suck eggs. But it is important that that's filled in so that they can actually determine what level of anaphylaxis it was, or whether it actually was true anaphylaxis. So I've put just a couple of slides together as well to support the fact that they are getting quite a significant number of cases coming through, which when they actually find the details out afterwards, had some warning signals of possible anaphylaxis, but actually didn't have enough information to support a true diagnosis of anaphylaxis. And obviously treating somebody that's maybe having an asthma attack or an hyperventilation episode with adrenaline just makes the situation worse and doesn't resolve it. So these forms are after the event, fill them in, and there's information at the bottom of the form that will tell you where to send them, how to send them through to the Dropbox at CALM, and they will then be linked to that person's episode that you would have logged on CIR as anaphylaxis. So as you all know, anaphylaxis is life-threatening, and it's a systemic hypersensitivity reaction. So the key points when you're doing your quick diagnosing, and these are just a few hints and tips, it's rapidly developing and it's life-threatening. And then think about airway and or breathing and or circulation, and usually some skin signs as well. So tips. bear in mind at the back of your head, be a smidgen sceptical. Lots of other things can go wrong post-vaccination. It's much more likely to be something else. So just have a hint of skepticism in your mind. Anaphylaxis is very rare, even in those people who have had slightly higher risks, so have anaphylaxis to other products. But there is still time to assess. It only takes 20-30 seconds to do a very quick A to E assessment. So use a systematic quick assessment to reach your diagnosis. Don't just, they've got a bit of a wheeze, I must grab the adrenaline. Actually, let's work it through logically. And only stop the assessment process if you've got a life-threatening problem. So if you've got somebody whose airway is obviously swelling and they are struggling to breathe, of course you're not going to worry about circulation, blood pressure, whether they've got a rash under their top or anything like that. You're going to grab your adrenaline. But if you've got somebody that's got a breathing problem, say they're breathing very fast, maybe they've got a bit of a wheeze, be a smidgen skeptical and think, okay, I can't see a rash, I can't see any facial swelling here, they're still communicating with me, they're still talking to me, I've got time to carry on with my assessment and see whether I can link it to problems with the circulation or skin changes, in which case, yes, I have got reason to reach for my adrenaline, or can I actually eliminate the other symptoms and think, is it perhaps asthma, or could it be hyperventilation? So using that logical system, airway problems, not life-threatening, let's carry on. Circulation. Now, I'm not suggesting that you rush and get a blood pressure cuff and try and get the right size and such like, and then you've got to find out what their normal blood pressure is, but simply holding their hand, feeling their pulse, is it weak and thready, doing a capillary refill, checking the squishing the thumbnail down for 5 seconds, how quickly does the colour come back? Quick ways of assessing whether or not the circulatory involvement. Are they feeling dizzy, lightheaded? Do they need to lie down? Is it just a faint? So it's that differential diagnosis that we've all been used to doing, but because we are aware that this vaccine has more anaphylaxis associated with it, I think some people are just not calming down and assessing a little bit too quickly. If you're not sure, even though you've done your circulatory assessment, move on to neurological disability. Do they have anxiety? Do they have agitation, confusion because they're not getting enough blood to the brain? And finally, exposure. Let's just have a little look and see if there's a rash there. Anaphylaxis doesn't always occur in the space of half a minute. It may take 4 or 5 minutes to develop. So you may go through your A to E assessment. I'm not happy with this patient, but I haven't got definite anaphylaxis diagnosis here. Call my colleagues over, we'll get the equipment available, we'll go through an assessment again, and now we're saying, yes, there is some circulatory problems here associated with the breathing challenge, or we've got some sort of a rash developing, so yes, we do need to treat with anaphylaxis. So hopefully, that will be just a quick reminder and will stop us from having slightly too enthusiastic use of adrenaline. Yes, it's safe, but obviously for certain people, particularly if you're stressed or if you've got a history of high blood pressure and you've got heart disease or you've had TIAs in the past and such like, calming it down and making sure you really can justify why you want to use your adrenaline before you jump in and use it. So that's the last bit I wanted to do. And now we'll go over to the questions, and I know some people are asking questions particularly around how to find resources.
So just remember, just instead of raising your hand, please type your question in if possible in the Q&A function below.
Okay, should I read the questions out?
Yes, go for it.
Okay, so the first one, can you please post up the link to the new drawing up instructions? I can't see it on the written resources section on the COVID Immune website.
Brilliant, I'm very impressed. Somebody actually knows where to look for it. Written resources is where all of these resources will go. But the new document is not loaded there quite yet. There's been a discussion about whether we change the colour on it to make it easier to identify that it's the new one. But the decision's just come through that actually we're more keen to get the latest guidance out than we are to worry about the colour. So it will be under written resources, but it is a ministry document as well. So it will be going out via HCL with your boxes of vaccines. So make sure you look out for it. It will have the date on the side, and you'll notice it's got more information. It's more detailed. And so really important that you look out for that one. Make sure you get it on the wall, laminate it so that you can refer to it. And also, while you're on that resource page, please make sure, as Olivia's already said, the vaccine screening guidance, really important. One side gives you all the questions you need to ask, as she's showing you there, and the other side just backs up some of the practical information that we've got in the updated vaccine prep. So most of it's staying the same, but make sure you're using the latest version of that. And then lastly, the resource of vaccine administration that talks in more detail about the extremes of sizes and the cold chain. Yeah, I could say if you got it there. That one, no, that's the vaccine.
This is the old one.
That's the vaccine prep.
Oh, yeah. No, I don't have the other one. No.
It's got a flow chart on the front around cold chain, and on the back it's got information about vaccine preparation. It's a summary document around practical issues, so that's another useful one for you to have. When you look at our written resources on the COVID section, you'll notice there's a date on them. It says new and then it's got a date. So look for the new July ones, and we put them in order, and you can quickly pick out the latest ones.
So that was an answer to another question. So number 3, we need this form for our sites, please. Where do we get this? What form is that?
That was to do with the reconciliation of the vials.
The dilution form, we can put that, we'll put that on the website. That's a good point. Or if in doubt, you can get it from your RIA, your COVID team member, but we will, that's a good point. I'll make a note that we put that on the website in that written resources place.
Okay, and another question, Olivia, you said you'd like to answer this. Can I clarify, second check-in, is that for every dose drawn up?
Yes, it's nice and easy. Every single dose going out there needs to have 2 eyes on it before it reaches the vaccinator.
And
please and thank you.
You have to have the documentation to say that that's been done, and that documentation has to be really clear that goes out with every dose of vaccine. And you will notice that there's going to be even stricter guidance as the programme rolls out, as we're getting bigger numbers through. We just need to make sure that everything is working really smoothly. So the reconciliation, which would be done on the smaller sites, sort of every time you've done a morning session or an afternoon session, at the big sites, even on an hourly basis, making sure the number of vials used matches the number of doses and the number of empty vials you've got left as well. So you're counting them in, you're counting them out, you're making sure. All that cross-checking is really important, just for everyone's confidence. Right, okay. Any other ones, Renee?
No, I think that's it. That is it.
The only other thing I would just emphasise, which I know we've mentioned a couple of times, this 21 days, if it's actually exceptional circumstances it's given earlier, and Renee gave a couple of ideal examples, but it's unusual to give it early. So really do make sure you get medical advice and not just say, oh, well, it'll be fine a day or 2 earlier. You will find that there's a lot more quality control coming in now, and you will get your knuckles wrapped if you don't make sure that you're following the rules. So must be over 16, must be 21 day minimum gap between doses, and day 1 is 0. You know, so the day you have your vaccine is day 0, I should say.
Okay. We had someone else that's asked a question about the question raised at 12:21. Jane did answer that. The question is, can you advise where to get information on exactly how to change the 38mm needle? We haven't used it and want to replace another smaller needle, please. Thank you.
Okay, good. I'm glad that somebody's owning up. Yes, it's on the vaccine prep, but also on the other document, the vaccine administration document I was talking about, the one with the...
Yep, that one. Yep. It's on the back of the A.
Yep. So that one, and the one with the flow chart on the front.
Oh, yeah.
The mRNA vaccine preparation document. So basically what you're doing is you must have vaccine in your needle. That's the important thing. You can't just swap your needles over, because the longer needles are not low dead space. They will hold a certain amount of vaccine in them. So if you've got 0.3 in your syringe and you swap the needles over, you're going to end up losing the vaccine that's in the needle. So you have to make sure that that needle's primed. And the way to do that is to draw the vaccine dose up with the longer needle in the first place. So every vaccinator should always have at least one dose in front of them of the longer needles. Because let's face it, we know New Zealand is a large country. And, you know, really the most countries would say anyone over 90 kilos as a female or 110 for a male. That's the one, Olivia, thank you.
Yeah,
on the back of that, there's more guidance.
It's
sizes.
At the back.
Down here, here,
Streams
and then
size.
swapping it over is...
So I think we're all a little bit reluctant. We all think it's going to hurt too much, but actually most people would not, well, people won't notice the difference, but we will be reassured that the vaccine is getting into the muscle. So it's not just your extra obese people, it's actually quite a large percentage of our population would benefit from a longer needle. So hence at least one longer needle available at all times. Once you've used it, ask to have another one. But make sure you don't muddle your batches up, because your expiry date will be 6 hours from when they were drawn up. So you have to make sure you're using them within the right timescale and not having them sitting around for any longer than necessary.
Great, thank you. There's another question here. Where is the guidance? Are we using the box expiry dates instead of a bio date? Okay,
it's written in our 3 new documents. We have been in consultation with the ministry because there has been confusion around this. So this is why we're really keen to clarify it on this webinar. It's going out in the operations guidance. So it will be, and it's, you know, CIR know that it's going to be entered in there, because at the moment there's confusion. If the batch number is not the one off the box, then the expiry date that you're writing in off the vial is wrong. The expiry date has to be the 31 days after the vial was defrosted. And so it's pointless looking at the expiry date on the vial. But there has been confusion because the original data sheets say that you have space to write the expiry date on the vial, and that's where the confusion came in, because we thought people could write it on there and then you would copy it off the vial. That doesn't work, so we've ditched that. We're now saying you have to have a clear label that has it written on, and you will take the information from that label as a vaccinator when you're entering it into CIR. So well spotted, it is new guidance, and over the next week or so you'll see it's coming in all over the place. But that's why we're updating all our resources today to reflect that change particularly, and the guidance around syringes and needles.
Thanks, Jane. Now another question, what about vaccinating a second dose later than 3 weeks, and how late?
Okay, so any time after 3 weeks is absolutely fine. And in fact, one of the things I had jotted on my notes to mention is that although we've been very clear that actually it's fine to give vaccines to people in, you know, most situations, if in doubt, ring 0800. There are some circumstances where people have had severe reactions to the first dose that aren't anaphylactic, but have caused other problems, for example, myocarditis and such like. If they've had a severe reaction to the first dose, then they need to be, medical needs to review them. So if that hasn't already happened by the time they come through, you can use our 0800 clinical team for that advice. And sometimes they will say delay the second dose. Don't just assume that as long as it wasn't anaphylaxis, it's fine to have the next dose. Actually, that is the other one that we need to be aware of. If they had a severe reaction to the first dose and they're concerned about whether or not to have a second dose, usually the severe reactions will be followed up via CALM, and the patient should have been involved in the process and will know the guidance and may come with a letter to say to you, yes, it's fine for me to have my vaccine. But if they raise a concern that they've had a severe reaction, not anaphylactic, but they're worried about whether they should have another dose, ring through and check with us. Most times it's fine, but very occasionally we'll say delay it.
I was just going to say, and if it's not a reaction, some people are saying, oh, overseas I've heard, and there's a question there about 12-week gap. They can get it whenever they want. That's their informed choice. The 90 to 95% effectiveness has been found at a 3-week gap. So if they want to take the advice of a doctor over in the UK or their own GP, then that's fine, that's their choice. 2 doses have been proven to be very effective compared to 1. So as long as they're getting that second dose, but if you want that really high efficacy, as found in the clinical studies, and we've got data on, it is a 3-week gap, but there is no maximum. They are always better to get their second dose at some stage.
And I think we need to be aware, I mean, there is quite a lot of data coming through from the UK as well, that actually delaying that second dose hasn't caused major problems. We're keen to keep people in process and get those vaccines done, but there can be occasions where it actually may be beneficial for certain people to delay it. And also, it's not that your effectiveness will drop as long as you get your second dose in. We just haven't got the data. We do know it was incredibly effective in the UK, where they consciously chose to have a longer gap. So people don't need to be too worried. Oh, I can't come back next week. Can I have a day early? Doesn't matter. Leave it till 2 weeks later if you're off on holiday and come back. We just want you to come back. That's the important thing.
Thank you. Another question, what ingredients in the vaccine are people getting allergic reactions to?
There's very little in the vaccine that people will be allergic to. So it seems to be a combination. It seems to be some people's immune systems are just hypersensitive, and therefore they are reacting. So I don't think it's one particular part. It's probably the PEG part of it, but we don't know for sure. So it's not necessarily somebody that we've seen that's had a previous anaphylaxis. It's those people that have more of an immune system that over responds to certain substances that occasionally will respond to these vaccines inappropriately, if you like.
Thank you. A couple more. When drawing bulk vials says takes 1 hour, how to document the 6 hour expired times?
Well, what you should be doing is you're doing one tray of from that vial, label goes with that tray, time of expiry, that tray. Next one. So you're not doing bulk trays of an hour's worth of vaccines in one go. And obviously, you know, so it should be vial at a time, and the labeling should reflect that vial, and you should have a log of each vial that you draw up, what time it was drawn up, what its expiry time is, and how many doses you've got out of it.
Okay, I think that's the last.
Well, that's good timing because we've just hit 1 o'clock.
101.
Yeah.
All right. Thank you all so much for joining us. And just keep an eye out for some more webinars in the future. Thank you very much for joining us. Ka kite.
Ka kite.